Thank you, ma'am, for the kind introduction. Good afternoon to one and all. At the outset, I would like to thank Dr. Mohan for giving me this opportunity to talk on this challenging topic of GDM monitoring and outcomes. The mainstay of treatment of GDM is medical nutrition therapy and exercise. However, a small proportion of women might require medications for glycemic control. And monitoring is an important tool for assessment of treatment in GDM. And why is monitoring important? Over-treatment of GDM can result in small babies. Under-treatment of GDM can lead to large babies, risk of hypertension in the mother during pregnancy as well as stillbirth. Hence, frequent assessment and prompt diagnosis in management is crucial to optimize glycemic control and good outcomes. Now, there are two components for the monitoring of GDM. The first is blood glucose testing, antepartum, intrapartum, and postpartum. The second is ultrasound monitoring for fetal growth as well as amniotic fluid measurements. First, coming to the monitoring of blood glucose and outcomes, I'll be discussing this under two headings. The first being glucose measurements, the methods including self-monitoring of blood glucose, venous blood glucose testing, continuous glucose monitoring, flash glucose monitoring, HbA1c. Frequency and timing and recommendations for these methods I will elaborate upon, followed by glycemic targets. Self-monitoring of blood glucose is the preferred method of testing, and the measurements are usually taken by a handheld glucometer, and what is measured is capillary blood glucose, and a log of this is maintained. However, it has disadvantages, which is it misses in between hypo or hyperglycemic events. Although this is an advocated method, there are still barriers for self-monitoring of blood glucose, including non-prescription by healthcare providers and poor perception of fear by the patients. However, the systematic review has also shown compliance with use of smartphone technology and education. Venous blood glucose testing is still being carried out in various parts of India due to technical issues with prescription of self-monitors for blood glucose testing. However, it is cumbersome. Compared to venous blood glucose testing, self-monitoring of blood glucose has been shown to reduce the incidence of macrosomia and large for gestational age babies. The frequency of blood glucose testing is still a question of ongoing debate. The number of times in a day to test as well as number of times in a week or more, there's still lack of clarity. There are few studies which have tried to address these questions, and we'll have a look at them. Number of times in a day, 2 versus 4 times testing, 4 versus 7-point testing. There has been no difference in outcomes based on the number of times you test, as well as number of times in a week or more, daily versus every 2-3 days, or weekly versus 2 weekly. Again, there is no difference, but it has the added advantage of increased compliance and decreased need for anti-glycemic treatment with less frequent monitoring. However, one important point to remember is all these studies have been done in women with well-controlled diabetes, and it cannot be extrapolated to women who have type 2 diabetes or GDM who are on medications. The next question is timing of blood glucose testing in relation to a meal. So should we be doing fasting alone, preprandial, postprandial, 1 or 2 hours? So the evidence is still not out as to what has to be done, but let us see what it has to say. The fasting blood glucose, higher fasting blood glucose was associated with increased neonatal fat mass. Hence, fasting blood glucose has to be tested in GDM women. Next, coming to preprandial blood glucose, it is usually carried out to determine the dose of insulin for control of blood glucose prior to a meal, or the carbohydrates consumed during the meal. It does not tell us if the insulin dose was correct or if the postprandial hyperglycemia is continuing, because postprandial hyperglycemia is the most important factor for development of macrosomia. Hence, it is not routinely done in GDM. The only indications are multiple daily injections of insulin or women on insulin pump. When postprandial was compared to preprandial blood glucose, it was shown that it improves glycemic control and decreases the incidence of macrosomia. A recent systematic review comparing 1 hour versus 2 hour postprandial glucose targets showed that there was a reduced incidence of large for gestational age babies with use of 1 hour testing when compared to 2 hour. But an important point to note is that a stricter postprandial value of less than 120 milligram per deciliter increases the risk of preterm delivery. But this was not of statistical significance. So worldwide, the recommendations for blood glucose testing, as you can see, different organizations recommend different things, especially pertaining to the frequency. Most of the organizations do agree that yes, self-monitoring of blood glucose is the recommended method. Fasting postprandial, yes, needs to be done. But preprandial is only indicated in women on multiple dose injections or on insulin pump. The frequency, it's slightly confusing. We obstetricians like to keep it simple and probably follow, yes, the American guidelines. So if I have to see a woman with GDM, I would advise her to test blood glucose 4 times a day, fasting, and 1 to 2 hours after each meal weekly. And further, I would tailor it based on the glycemic control, whether I wanted to do it frequently or less frequently. Next, moving on to continuous glucose monitoring and flash glucose monitoring. This measures interstitial fluid glucose. The advantage is it gives us the picture of trends and patterns compared to venous or capillary testing, which provides only a snapshot of the blood glucose. But the disadvantage is, yes, it's expensive. The international consensus on time in range advocates the same target values in pregnancy as advocated for type 1 diabetes, for GDM also, but the time in range for each of these categories has not been quantified. This was a systematic review published by Mohan sir et al. Just 2 days back, and this had evaluated 35 studies, and it had shown that CGM was associated with significant improvements in maintaining glycemic control as well as correlated with favorable outcomes such as LGA. It detected more hyper and hypoglycemic events, particularly nocturnal fluctuations. But however, as I pointed out earlier, the CGM metrics has to be standardized. FGM also appears to be comparable to self-monitoring of blood glucose, and it's well accepted by patients with numerous advantages. In conclusion, the recommendations for CGM and FGM in monitoring of GDM, the ADA in 2025 mentions there is insufficient data to support its use, and the NICE UK guideline mentions that it can be used in women with severe hypoglycemia and unstable blood glucose. However, the decision should be individualized based on the treatment plan, the patient affordability, etc. Next, moving on to HbA1c. It's an index of glycemic control over 3 months. It may be used to verify reliability of SMBG. In a patient where the blood sugar profile looks normal, but the baby appears large for gestational age on ultrasound, or there's polyhydramnios, I might want to verify if the blood sugar profile is reflective of what's happening with the fetus. In that case, if I want a snapshot of what has happened over the last few months, I would definitely do a HbA1c. But points to note would be, it may be spuriously increased consequent to iron deficiency anemia, and it may not fully capture postprandial hyperglycemia, which is a driver of macrosomia. Recent systematic review showed that high HbA1c levels are associated with increased large for gestational age babies, and further research is required to evaluate its utility. The recommendations for HbA1c monitoring in GDM, the ADA says it can be used as a secondary measure of glycemic outcomes after blood glucose monitoring by self-monitoring of blood glucose. The NICE UK guidelines mention that it should not be routinely used for assessment of control of blood glucose. Next, moving on to the glycemic targets, antepartum, intrapartum and postpartum. Majority of organizations have come up with cutoff values for fasting, post-meal and 2-hour. This is based on consensus rather than hardcore evidence. And the cutoff values for fasting is less than 95, 1 hour less than 40, 2 hour less than 120. Pre-meal usually not done in gestational diabetes, only when they are on multiple daily injections or on insulin pump. The cutoff value is the same as fasting less than 95. The ADA in 2025 also gives us the lower limit cutoffs for monitoring, that is the targets, which is 70 to 95 for fasting, 110 to 140 for 1 hour, and 2 hour 100 to 120. ADA has identified these lower limits to prevent the occurrence of small for gestational age babies. For CGM, as I mentioned before, the targets for blood glucose control is 63 to 140. And the ADA in addition for HbA1c, if it is used as a method of monitoring, it is less than 6%. A recent Cochrane review which evaluated different intensities of glycemic control for women with GDM found that tight control when compared to less tight glycemic targets, there was an increased requirement for pharmacological therapy as well as reduced adherence. As I mentioned before, the targets are based on consensus and there is no hardcore evidence. So there still remains limited evidence regarding the benefit of different glycemic targets for women with GDM to minimize adverse effects of maternal and neonatal health. Next, moving on to the ultrasound markers of glycemic control and outcomes. Hyperglycemia in the mother increases the fetal abdominal circumference due to deposition of fat in the subcutaneous tissue and as well as the glycogen in the liver and leads to increased fetal weight. It also increases the chance of polyhydramnios. Systematic review which compared ultrasound fetal growth versus strict glycemic treatment in singleton pregnancies showed the reduced incidence of macrosomia when these women were managed with fetal growth measurements. The recommendations for ultrasound antepartum are fetal growth amniotic fluid index from the time of diagnosis 2 to 4 weekly. But then this can vary based on glycemic control. If I see a woman with GDM controlled on diet, I might want to do it only every 4 weekly or even 4 weekly. But if a patient is on medications and the sugars are not controlled, more intensive monitoring might be required for the amniotic fluid index, although the growth can be measured every 2 weekly. The targets for fetal weight growth is less than 98th percentile. So if anything is more than or equal to 90 percentile or the amniotic fluid index is more than 25, the management needs to be intensified. Intrapartum recommendations for blood glucose testing. NICE UK mentions hourly monitoring, whereas DIPSI mentions 2 hourly monitoring. Commonly, yes, 2 hourly blood sugars are tested in our setup. The glycemic targets by all the organizations are 72 to 126 milligram per deciliter. Next, moving on to postpartum recommendations. In most cases of GDM, the diabetes resolves after delivery. 6 to 12 weeks after delivery, 75 gram OGTT is advocated. If normal, 1 to 3 yearly testing is advised. However, diabetes can persist in 5 to 10% of cases and may represent pre-existing diabetes. So, women with GDM on medication, it's advisable to do a blood glucose measurement, fasting and postprandial 48 hours after delivery before you discharge them from hospital. Otherwise, you'll be missing an opportunity to be screening these women. As Mohan sir said, once they have delivered and gone back home, they don't come back for testing again. So currently in JIPMA where I work, yes, we do blood glucose testing for women on medication before they go home. Role of e-health medicine, telehome care and new technologies. Yes, in this era of rapidly increasing GDM diagnosis, e-health care allows for two-way communication between the patient and the healthcare provider. And a systematic review has shown that there is no significant difference in glycemic control and maternal fetal outcomes compared to the standard care group. So the take-home messages from today's talk on GDM monitoring and outcomes. GDM monitoring, there are two components. One is the blood glucose testing and second is ultrasound monitoring of the fetus for growth and amniotic fluid index. Self-monitoring of blood glucose is what is recommended by majority of organizations worldwide. If not feasible, yes, venous testing. Continuous glucose monitoring, there's insufficient data at present to recommend as a first-line blood glucose monitoring testing method. HbA1c, there is more research regarding utility, but then when you're not very sure of the accuracy of your self-monitoring, then yes, you could do your HbA1c levels to see how her sugars have been over the past 3 months. The most controversial topic I would say is the frequency and timing of testing, which needs to be individualized. But to keep it simple, antepartum women with GDM, yes, they need to undergo testing, fasting, postprandial, either 1 to 2 hours, 4 times a day, weekly. And the targets are less than 95 fasting, 1 hour less than 140, and 2 hour less than 120. Ultrasound for fetal and amniotic fluid index 2 to 4 weekly. However, this is only a basic minimum. If the blood sugars are abnormal and the glycemic control is poor, you will have to intensify the frequency as well as the timing of monitoring. Intrapartum monitoring is every 2 hours. Target blood glucose is 72 to 126 milligram per deciliter. And postpartum, if she is not on medication, then 75 gram 2 hour OGTT, 6 to 12 weeks postpartum. If normal, then 1 to 3 early thereafter. If on medication, please at least do blood glucose testing, fasting and postprandial 48 hours after delivery before she goes home from hospital. E-health appears to be beneficial both for the patient as well as it might reduce the burden on the healthcare system at present. Adverse outcomes such as macrosomia, large for gestational age and poor glycemic control can be minimized with optimal monitoring. Thank you.
Thank you, Dr. Sari.